Okay, so we are starting now. Okay. So I hope I'm audible because I'm going to start soon. Okay, so we are starting now. So everything is perfect, I hope. So we'll start. Okay. So first of all, welcome all of you to the class. Okay, and no need to say thank you again. I'm always with you because what I've learned and my mother taught me, helping people is not just the duty of doctors. Okay, all humans should help each other, and that is what all the human society is built upon. Some of us are doctors, some are lawyers, some are engineers, and they help each other. That's why the entire system work. Okay, so if as a teacher I'm not helping you and you students not studying, that will not be helping me. So we are dependent on each other. A bad teacher will cause bad education, and bad education will create bad citizens. They'll not be good at any work, and ultimately it will collapse entire system. So I want you people to become very good doctors and very good human beings and help each other. Okay, so that's the case. Okay, fine. Yes, full physiology would be covered with clinical case. So we'll have classes for 5 days, full physio 5 days classes. Okay, I always want to take full physio classes for free, first time getting a chance. Okay, because yes, not all institutes have such a big heart to allow full subject for free. Okay, so only some can do it. Okay, full physiology. Okay, thank you Babita. Okay, full physiology 5 day with all the MCQs. Okay, and I'm trying to get some other subjects for free, full physio for free, if possible other subjects also. Otherwise you always have an option of using app or whatever books you are having. Whatever free I will try to provide, whatever is paid obviously you have to pay, but I will try to make sure that if you have to pay, you pay the minimum. Okay, so we can always make sure that no one is overcharging you, no one is cheating you. Okay, if there's any overcharging, cheating, do inform us. We will talk to that institute or this ki why are you cheating the students. Are you clear? Because now we have a very big voice, no one can ignore us. No more cheating or banning students from their classes or stopping their subscription, because no, I will not allow that. We want everyone to study and pass. Okay, chalo. Are pakka bhai Indrajit, I will do, don't worry. Okay, clear? So these videos would be available. Okay, these videos will be available for a very long time. Okay, till you all see. Okay, plus app, Bharti app, they'll be available till exam. Okay, so if you are seeing this in Bharti app, DBMCI app, so those who are already having the app, at least physio lectures, so they'll be available till the exam. Okay, so available till exams. Okay, so it's not like that some institute who delete on the same night. Okay, it will not be the case, because I already talked to the institute that I want the lectures to be available, because some students have other things. Okay, they might be having some flight issues, not able to watch, internet issues. So obviously it's online, you should make them available after the exam. It's not something ki I cannot do, so it should be stopped. Okay, okay. अरे यू डाउनलोड द ऐप ना, कितनी बार बताया इसको. तो भाटिया ऐप में यू कैन वॉच द फुल फिजियो लेक्चर्स टिल एग्जाम्स ऑल्सो. यू विल हैव द लेक्चर्स अवेलेबल. ओके, बाकी ये सब चीज़ें हम बाद में करेंगे, अभी पढ़ाई की बातें करते हैं. आ जाओ. ओके ओके सारा यू गिविंग अ कॉम्प्लीमेंट, इट लुक लाइक क्या है, अपने घर के लोग तारीफ करें अच्छा लगता है. ओके, you know, okay, that yes, okay, we all are family. Okay, and you are very close family. Okay, you 5-6 people who are working this group. Okay, day and night you are helping, making MCQs, making questions, attending each and every query of students. So thank you very much. Okay, yes, some delete within few seconds. Okay, अब यार पैसे दे दिए तो मैं क्या कर सकता हूँ, ठीक है ना. Okay, if I tell you I fought so many times with that institute. Clear, I was a partner. I said, sir, please reduce the fee. Okay, it's too much. It's only 4-month coaching, sir. We start the batch in Jan Feb and June exam is there. We start the coaching in July, August, December exam is there. For 4-month coaching, 88,000 is too much money. Please reduce the price. But no, sir, we need this much money to have some profit and do. So again, finally it's over. Chalo, so let's start the question. Okay, chalo. So let's start. Okay. Okay. Schedule year only once the batch is finalized I can give. Bhartiya people will be closing the batch admissions. Once they close, they will give a schedule, and that was I will give. App, I will give a schedule for classes very soon. Okay, so schedule very soon, please wait for that. Okay, schedule soon. Okay, clear? Plus full strategy for preparation would be given. Okay, so let me start. Okay, so first is, as I was discussing, what the concept of hydrothorax, pneumothorax and all the pleural effusion. Okay, so first let me start with what the normal cavity contains. So normal pleural cavity contain pleural fluid. Okay, so what is the quantity? It is around 5 to 10 ml. That is a pleural fluid. Okay, clear? So what is the quantity? It is around 5 to 10 ml. Are you clear? And question is, what are the abnormal conditions? So first is, we can have something called as pleural effusion, or we can have a hydropneumothorax, or 3 they can ask is just pneumothorax. Just pneumothorax. Okay, so these are the 3 main concepts. Okay, clear? So 3 most. Okay, okay, so pleural effusion, hydropneumothorax and this. Okay, so in this case there is increased fluid. Okay, and one of the most common features, what it causes, what blunting of CP angle, that is costophrenic angle. Costo means rib cage, phrenic. So I'll just show you costophrenic angle. So what is the thing? It is blunting of CP angle that you see on the X-ray. Okay, on what? On chest X-ray. But problem is, it requires at least 150 ml of fluid for what blunting to be seen very properly. So let me just show. Okay, so can you see this thing? Okay, this is called as CP angle. Can you see this thing? So this is the costal, this is the diaphragm, phrenic. So this is the P part, this is the C part, costo and phrenic. This is called as CP angle. So can you see it's very sharp? So you can see the CP angle is very, very sharp. Okay, as it get blunted, you have what? It will become like this. Okay, you will see a blunting and you will see a border here, not at this point. Okay, clear? So if you are seeing no CP angle, it is one of the indicator of what? Pleural effusion. Are you clear now? So CP angle blunting is the case. Are you clear? Okay, now the best X-ray is lateral decubitus. So we can do a lateral decubitus to see it for a proper understanding. So which X-ray? Lateral decubitus. So that's why you will make the patient lie on the side and with the legs folded. Okay, that is called lateral decubitus, and you can see the blunting at the lower end. Okay, that is called what? This. Okay, and it can detect up to 5 to 30 ml of fluid. Okay, chest X-ray require 50 to 150 ml at least of fluid. So that's what is better, decubitus or chest X-ray. And the best is, and even better is ultrasound. Okay, ultrasonography, it is up to 5 ml. So even if it is 5 ml, you can detect with the help. So decubitus study say can be as low as 5, but what is always the 5? So that's why the best is ultrasound. Okay, and even better is CT. Okay, clear? And then CT is even better. CT is said to be best. Okay, so CT is best for that. Okay, why? Because ultrasound also can sometimes miss some of the fluid pockets, but CT is said to be best. Okay, that's what as I learned from radiology. Okay, clear? So if they ask in the exam which X-ray, cubitus, but if they give cubitus versus ultrasound, then ultrasound is superior to decubitus X-ray. Are you clear now? And it is said CT is better than ultrasound in this case. Are you clear? So let's see that. Okay, okay, this is the lateral decubitus. Can you see? So person is lying on this side. Okay, this is the fluid. Can you see the fluid? So this is the fluid. Can you see? This is all fluid. This white is fluid. This is the fluid. There is no CP angle here. This is fluid. Okay. So this is the fluid. Okay. I hope it's clear. And also it can tell you whether it is localized or free. Okay. Fine. This lateral decubus. Okay. So please take this photo. Okay. And see. Okay. 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 Also show. Okay. Okay. Now this is what is, this is not pleural effusion. Why? Because you can see a very straight line. In effusion you will not see a very straight line. A very straight line indicate what? Air fluid level. Air fluid level. So this is basically hydropneumothorax. Okay, so there is what? A very straight line. This is all fluid. This is all fluid, and you know fluid create a straight line. So if you see a very straight line, then it is hydropneumothorax. Are you clear now? Hydropneumothorax. Okay. Here also you can see this. Again, it's a lateral view. This is the anteroposterior view. So this is again what? Hydropneumothorax. This is again hydropneumothorax. HPT. Are you clear? Yes. So these are hydropneumothorax. Okay. Done. So what we have learned till now? We have learned pleural effusion and we have learned hydropneumothorax. What are the characteristic? Here you see a air fluid line. So I know it's sometimes confusing, but simple idea is what? If you see only blunting, like this is the case, this would not be what? Hydropneumothorax. It will just be pleural effusion. Okay. But if you see a straight line, then most likely it is going to be hydropneumothorax. Okay, clear? Now we see just pneumothorax. Okay, so as I told you, pneumothorax, what happens? The collapse occur. So in pneumothorax there is collapse. Okay. Okay, so I just first, so we have learned that in pneumothorax there is collapse. Okay, so as the lung collapse, the tracheobronchial lung markings are gone. Why? Because there is no air, so there is no markings of the lungs left. So loss of lung markings. Okay, so there is a loss of lung markings. Okay, plus the mediastinum will shift, shown by tracheal shadow. So these two are very important, and you can see by what? The shifting of mediastinum, that which side collapse occurs. So obviously it will cause a shift to the which side? See, lung is collapsed. So this is what? Less pressure. Let me show. Okay, see, this is first thing. Can you see? These are lung markings. Can you see these lines? So these white lines, these are lung markings. Here there is no lung marking. Why? There is only air but no what? There is only air but no lung. This is a collapsed lung. Can you see this? This is, I'll use a bigger pen to show, or rather a white pen, bigger one. Okay. So can you see this thing? This is the collapsed lung. So what is this thing? This is the collapsed lung. Can you see? And these are markings. Okay. Clear? So the collapsed lung. Okay. Can you see? Collapsed lung. Okay. 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 See, hydro and pneumo is tough to identify because if blood, but mostly the blood is going to clot. Okay. And based on that, we are going to try to find out the reason or etiology. Okay. Clear? Fine. So is it clear? So this is the collapsed lung and the mediastinum is shift. Can you see? This is tracheal shadow. Can you see? So this tracheal shadow, they are shifting this side. Okay. So that's why in case of left, the shift will be to the right side. Are you clear? So left lung is collapsed and that cause the shift of the mediastinum to the right. So can you see? It is shifting to the right side. So this is what case? It is a left pneumothorax. So what do you see? Only air, no lung markings. Plus this is a collapsed lung which is lying at the bottom. Okay. And it is shifted to the right side. So these three are the findings. So pneumo is air. Okay. Pneumo is air. Okay. So let's do rapidly and look at this also. Can you see this white thing? This is the air. And this is a collapsed lung. This is the collapsed lung. This is the collapsed lung. This is the collapsed lung. Okay, can you see? This is a collapsed lung, this is the heart, okay, this is the normal lung, and you can see slight shifting. So therefore this slight shifting shown in this case. I hope it's clear. So see, it is tilted like this, okay, so this is the case. I hope it's clear. So this is again what? This is again pneumothorax. Pneumothorax, okay. Now in case of tension, what happens, I'll explain, okay. So I hope everything is perfectly clear till now, okay. Now let's come to the 2-3 points, okay. So first, are you able to identify all? Let me give a rapid recap and you should tell me, okay. If you see straight line, it's a hydropneumothorax, clear, straight lines, okay. If you see only black without any lung markings, it is what? It is a pneumothorax, and you can see a collapsed lung at some corner, okay, that's the case, plus shifting of mediastinum from the tracheal shadow. Can you see the trachea shifted to this side, okay. Then this is again the same thing in CT. In this CT, what do you see? You see the black air, which is pneumothorax, and this is the collapse of lung, okay. This is lateral decubitus view for what? For pleural effusion. You can see the fluid white, okay, air is black, okay, and this is again what? Pleural effusion. So it's again what? Pleural. So can you see the CP angle? There is no CP angle. This is what? And see the line is what? Curve. So it's most likely what? It is pleural effusion. Are you clear? It is not. So why it is not a hydropneumothorax? Straight line. Here you can see there is no straight line. So that's why it is not the diagnosis of hydropneumothorax. Are you clear? It is pleural effusion. Are you clear? This is normal. This side is normal. Normal CP. This side there is no CP angle. Are you clear? Okay. So done. Okay. So let's come back. Okay. Now some people are asking me, sir, what about this problem which we hear about the tension pneumothorax and close? Okay. So let me explain this thing once again with the help of diagram. Look at this. Okay. First is, if there is an opening here, this is called as open pneumothorax. So this is open pneumothorax. PT is pneumothorax, okay. If there is an opening in the alveoli, let's say some alveoli bulge out and this alveoli rupture. So now the air will come from where? It will come from the lung. So this is called as closed pneumothorax. So air is coming from rupture of alveoli, the blebs in the emphysema. This is closed pneumothorax. Okay. So what happens here? Okay, in closed pneumothorax, some emphysema will rupture and they release air into the pleural cavity, I hope it's clear. Okay. So I hope it's clear. Okay. So are you clear? Kushal will compare it with the you can say AP view, okay. So we can always compare the decubitus and always we take what? Normal AP view, then we take the lateral view. Na? How will you know that we should take a lateral? Are you clear? So if you're suspecting, take a X-ray. There's a CP blunting, you know this effusion, and then you want to know the exact this, then you take a lateral decubitus. So we can easily differentiate, okay. So some emphysema bullous rupture and this causes air to enter the pleural cavity. This is called what thing? Closed pneumothorax. Closed pneumothorax, okay. Then come the third one, that is tension pneumothorax. What happens here is there is a valve created. What valve? One-way valve. So air enter, but can't go back. Are you clear? So when this person inspire, the air enter, okay. Like I'll give example. Look at this flap. Can you see this flap? I use a green pen to show. So look at this green pen. This is the flap. Can you see? Flap. So this is a rupture. Now when the person inspire and the air comes, the air is pulled by negative pressure. Air can easily come in. But when this person try to expire, the pressure rise. This pressure will push this green structure and it will shift like this, okay. Are you getting the idea? And what happens? As this green structure attaches to the wall, it will block any air outlet. So air can come but can't go out. So air can come in but can't go out. So air enter but can't go out. So air enter but can't go out. Okay, so what's happening? The air is coming but not going out. Okay, clear? Fine? Okay. Now what is the result? There is very high, okay, very high ITP, plus 20 to plus 40 mm Hg. Are you clear? So the value now plus 22 plus 30 is the value. I hope it's clear now. So plus 22 plus 30 is the value in this case. I hope it's clear. Okay. Clear? Okay. And this will collapse the lung. Collapse the lung, and that cause sudden dyspnea. So are you clear? So it cause a very sudden dyspnea in this person. I hope it's clear. So sudden dyspnea will occur, okay, and this is the classical presentation. Are you clear? Okay. Now what is the treatment? So obviously you will insert another tube. Why? So that this extra air goes out and the pressure remain 40 or become 0. 0 is not going to kill you, but 40 will collapse the lung and kill you. So that is why we create an opening to allow this extra pressure to liberate itself. So that is why the treatment is what? It is what? You will create another opening, that is thoracotomy. Okay. So what we do is we'll do a needle decompression. Okay. So what do? We insert large bore needle. Okay. So I hope it's clear. So we will insert a very large bore needle called as what? Needle decompression or thoracostomy. Okay. Ostomy means opening. So you're opening this by large needle. Okay. Clear? In intercostal space. Now here is a controversy. Okay. Some books say 5th. Okay. But some book or most places it is 2nd intercostal space. Okay. Clear? Okay. So if there is any change in the guidelines etc, okay, we can just always find out. Okay. But what, as far as I know, it's 2nd intercostal space. Okay. Clear? Mid clavicular line. Okay. Clear? And if you put a chest tube to drain the pleural effusion, that is done at slightly lower level because you want fluid to come out. So that is done primarily at which level? It is primarily done at the level of 5th intercostal space. Okay. So I'll take a clarity later because even I don't remember it exactly. So what is the case? I will try to explain it to you once I get the full information from surgery. Okay. Clear? So I hope it's clear. Okay. Fine. Okay. All people are replying. Very good. Okay. Okay. So done. Okay. So insert a large bore. Okay. Clear? Okay. So start now. Okay. Okay. Now let's move on. Okay. ITP pressures, they will not ask you much, so you can skip it for now. Okay. Because I am very much sure they're not interested in ITP changes. Just remember one thing. Okay. During forceful expiration, okay, there is very high ITP. There is very high ITP. How much? Plus 20 to plus 30 mm Hg. Okay. Clear? So I hope it's clear. So there is very high ITP. Okay. Plus 20 to plus 30 plus 20 to plus 30 mmHg. Okay, all other conditions ITP is negative. So any other condition, the ITP is always negative. Okay, fine. So what is the summary? How do you people inspire? So I'll just write. So when you inspire, there is decrease ITP. Okay, decrease ITP due to expansion of thorax. And it become minus 6 mmHg from minus 2 mmHg. Are you clear? So it become okay. Then what happens? This expands lung and IAP becomes minus 1 and then air enter. Just write this much, you don't need to write everything, this is more than sufficient. So what is the funda here? I hope it's clear. So is it clear now? Okay. Done? Okay. So this expand the lung and IAP becomes what? IAP will become what? It will become, okay, it will become minus 1. Okay, clear? Okay. And regarding the gauge, I told you white bore. Okay, white bore you can use 14 or 16 gauge. It should be whatever is available. Okay, clear? Clear. If it's not available 14, you use 16. If not 16 also, we can use even 18. But remember, it should be wide enough to allow rapid decompression. Why? Otherwise the pressure will build up and cause the person to have no respiration, might die also. Okay, chalo. Okay, so air enter. And remember, for small pneumothorax, you don't have to do anything, it can spontaneously resolve. Only when the patient is having breathlessness, is having what, dyspnea, cyanosis, tachycardia, high sympathetic, only then you start decompression. Okay, for small pneumothorax, they resolve themselves. So write one more thing, small pneumothorax, they can resolve by themselves. Okay, resolve spontaneously. Okay, so if vitals are stable, no sign and symptoms of dyspnea or distress, okay, there is no treatment required. Okay, so as I confirmed with Dr. Singaram also, he told कि this is the answer for that question. Okay, so I hope this question was also there, yes or no? Okay, fine. So this question was there in the exam. Okay, fine. Okay. Okay. Okay, regarding sodium, glucose, regarding the joining, etc., you just message me. Okay, we'll discuss them later. So right now I'm just trying to give the free classes. Whenever you want to join for other courses, etc., we'll ask them to do a counseling session for you people. Okay, clear? So I'll ask them. Okay, so I hope it's clear. So discuss what? 2 MCQs. So 2 MCQs. Which 2 MCQs? Okay, let's go back. This was there in the exam, yes or no? This was there in the exam. Hydropneumothorax question, it was there in the exam, we discussed. And we have also discussed that small ones don't need much. So a small pneumothorax with vital stable, you don't do anything, it can be just wait and watch. So no difference, so wait and watch. No need to put the needle. Okay, just wait and watch. Okay, fine. So by the time I finish physio, I promise at least 50-60 question we will cover, not just in classes but also in the groups. We'll be focusing on all clinical scenarios. Okay, fine. Chalo. Let's move to next topic, that is called as the topic of compliance. So write down compliance. Compliance means stretchability. So it means stretchability, how easily the lungs can stretch. Now understand a very simple thing, normal elastic lungs have good compliance. They have good compliance. That means they can stretch very easily, okay, and good recoil as well. So that means like a rubber band, they can stretch and they can return, okay, clear? See, fifth intercostal space is preferred for insertion of chest tube, okay, clear? So I will clarify, that's what I'm saying, na? Whenever there's a controversy, always we say, please, we'll take a final version after that, okay? So this question of second intercostal or fifth intercostal is a controversial one, but one thing is sure, that chest tube is inserted in this. Why? You cannot put a chest tube much higher up, it will not be draining. So drainage via chest tube is done mainly in the fifth intercostal. So what is the case? I will discuss it in later part, okay? So please don't fight for that, okay? Let's wait and get the final version after discussion. But what I told you, needle for decompression is second, because you want the air to come out. So best you put where? At the top, so that it blow the extra pressure out, okay? Fine. Let's start, okay? So it is good recoil, okay? So what are the normal lungs are having? They have good compliance, they have good recoil, they can stretch also, they can return also. So that's why they will return back, okay? So that means they stretch in inspiration and they return back in expiration. Now diseases will affect the compliance and the lungs will become stiff, hard and unable to stretch. Like example, my shirt, if I try to stretch, doesn't stretch. It is inelastic in nature. It will rather be ruptured and torn. So my shirt is inelastic property, okay? So that means inelastic tissue have poor compliance and poor recoil. So therefore remember, all lung parenchymal. What is parenchymal means? Tissue. Okay. So all lung parenchyma. What does parenchyma means? It means tissue. So parenchyma means tissue. Okay. It means tissue. Okay. Clear? Fine. Okay. Okay. So Raj, I'll discuss. Don't worry. Okay. Clear? Because I told you na, whenever there's a controversy, we always take the ground where it is the best answer discussed. Okay. Clear? Chalo. Okay. So peds, adults, all, I'll give a final version. I just told you what I know from medicine, okay? So all lung parenchymal, and normally medicine people don't even do this, okay? We ask a surgery guy to do all our venous cut open, all fistula creation for dialysis. Dialysis is medicine people do, not nephrologists. But who will create the fistula? Surgery people. Venous cut open for creating this permanent access, IV access, this. Even IV line is inserted mostly by surgery people, okay? They are good at cutting ना, medicine वालों को काटना नहीं आता, okay? चलो. So all lung parenchymal tissue, okay, all lung diseases, okay, have poor compliance. Have poor compliance. Remember, they have poor compliance, okay, due to fibrosis. So because of fibrosis, the lungs become stiff. Let me give an example. Okay, I told you, take a rubber band, it can easily stretch. Now take a shirt, cotton shirt. Can it stretch? No, it will be ruptured. So that's why it is inelastic in nature. Okay, so this cloth is to some extent stretchable. Can you see? It can stretch, not too much, but it can stretch. Okay, but my shirt is almost non-stretchable. So they have poor compliance due to fibrosis, inflammation, infiltration. Are you getting the question? So fibrosis, infiltration. What does infiltration means? It is entry of abnormal tissue in the place of normal tissue. So what is the example? Example, asbestosis, silicosis, okay, pneumoconiosis, all are example of what? Infiltration. So what is the result? All these conditions will make the lungs very, yes, okay, clear? Okay, 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 fine. So now comes the question, what is the result? The result is, okay, so these diseases, okay, these diseases, there is reduced respiratory movements because of poor compliance. So these diseases, there is reduced respiratory movement, hence called as RLD, that is restrictive lung diseases. Are you getting the idea? So what is the name given? Restrictive. So now understand what diseases are restrictive, where the lungs cannot stretch properly. Very simple. So I'll give an example. Let's say the rope, okay, and I tie it around my chest, okay, clear? So I'll take an example. Let's say my chest, okay, and I tie a rope around my chest. So now I have difficulty breathing. Why? Because this rope is restricting the expansion of my chest and lung. That is called what disease? Restrictive lung disease. So what is restrictive? Unable to expand, stretch the lungs. So that's why he will have poor inspiration and poor respiratory values. Are you clear? They are called what? They are called as restrictive lung diseases. Okay, restrictive lung. Now they are of two types. What are two types? They are either external, okay, external or extrinsic rather. That is extraparenchymal, extraparenchymal, or they are intrinsic or parenchymal. Are you getting the point? So they are these ones. I hope it's clear. So they are these ones. Okay, clear? Extrinsic and this. Okay, fine. Now comes the question. What is the problem? Here the lungs are involved. So lungs involved. Okay, lungs are involved. Okay, so in this category, basically primarily what are the problem? The lungs are involved. Example, we have what? ILD, ARDS. Okay, now what is ILD? Interstitial lung diseases. What is ARDS? It is what? It is adult or acute respiratory distress syndrome. Okay, clear? Acute, okay, respiratory distress syndrome. So in this case, the alveoli are damaged, okay, and as there is a damage to the alveoli, there is what? Fibrosis, etc. The lungs are involved. There is fibrosis mostly seen. So that's why lungs are unable to stretch very well. Okay, call is what? This. Okay, fine. Okay, and what happens? As the lungs are becoming very, very small. So that is why this small lung volume. Okay, what is the hallmark here? The residual volume is low. So low residual volume. It's a very, very important question. I'll discuss it later. Whereas in extrinsic, the problem is not, okay, clear? The problem is not, okay, in the lungs, okay, the problem is in the chest wall. So the problem here, chest wall involved. Okay, so chest wall. So therefore, if the chest wall is not moving, how can lungs move? Lungs are mostly healthy. Okay, so lungs can be normal, easy ho gaya. So if a patient has restrictive lung disease, a patient is having restrictive lung disease, what are the two problems? Either chest wall is damaged, that is extraparenchymal, and if there is an involvement of lung, that is the parenchymal or intrinsic RLD. What are the hallmark? Just remember the diseases are different, and second is what? The RV is less because the lungs are, this is normal lung, let's say fibrosis. So now what happens? There is decreased space and decreased RV. That's called what? Residual volume. Okay. Now, if there is chest wall involved, what are the case? So one is it could be joint problem like ankylosing, okay, spondylitis or So joints are inflamed, they cannot move. So there is the inflammation of joint. Okay, clear? And very common word, it is HLA B27 associated. Very commonly asked question, HLA B27. Okay, so ankylosing spondylitis. Okay, then also problem of neuromuscular disorders. Neuromuscular disorders. Example, myasthenia gravis, or what, diaphragmatic paralysis. Okay, fine. So diaphragmatic paralysis. Okay, so if diaphragm is paralyzed again, so what is the result? Result is what? In all these conditions there is reduced movement, but not because of lung, but because of chest wall. So I hope it's clear. So very simple. Yes. Okay, so all these are important conditions. Okay, so what is the summary? Chest wall involve extrinsic, lung involve intrinsic. Chest wall, extrinsic, lung. So therefore the RV is very much preserved. So that's why there is a normal residual volume. So therefore if they ask you, you can diagnose by doing a proper examination. Okay, but if they ask you, like we do CT, MRI, etc., we can always find out what is the case. Okay, fine. Okay, so extrinsic or intrinsic is the case. Okay, done. Okay, now we will see the remaining concept. Okay, what condition the compliance is increased? Okay, so compliance is increased in which condition? Okay, compliance. Okay, okay, so compliance is increased in only one disease. Okay, so right, increase compliance, okay, and poor recoil. So increase compliance and poor recoil is a feature of which condition? It's a feature of which condition? It is emphysema. Okay, very important question. Okay, so emphysema is a very important. There is a, yes, so lungs behave as what? Like rubber band? No. So therefore lungs behave less as rubber but more as chewing gum. More as chewing gum. Are you clear? So lungs will behave less as rubber but more as a chewing gum. Okay, so that is a very important concept. Yes, phrenic nerve injury or a problem to the any motor centers like respiratory center, they all are diaphragmatic paralysis. Okay, it could be because of myasthenia gravis also or nerve injury also. Okay, clear? So honeycomb, oh they're just giving me. Okay, so lungs behave less as rubber, more as chewing gum. Now you take a chewing gum and when you stretch it, keeps stretching and stretching and stretching but doesn't recoil. So a chewing gum can stretch but doesn't recoil. So what happens? It will keep stretching, keep expanding but never return back. So that is what the lungs are. So what is emphysema? It is rubber like lungs. So what is emphysema? It is rubber like lungs which can stretch but never return back. Are you clear? Never return back. Okay, now to the pathophysiology of emphysema. So in emphysema there is a dilatation. So therefore what happens? There is a dilation of acini. So dilatation of acini. Okay, why? Because of what? Increased compliance. So dilation of air, this. Okay, clear. Also formation of blebs, bullae formed. So let's say the acinus, can you see? So this get dilated. So it will get dilated at multiple places. So this dilatation is called as what? Emphysema. Fula. याद रखना, emphysema means floated or what, क्या बोलूँ उसको, ठीक है? In Hindi, emphysema means fula. Emphysema is inflated. Okay, so emphysema is dilatation. Okay, and what is the reason? So reason are multiple, but remember two main causes. Okay, one is, so reasons. Okay, pathophysiology. Okay, is one is alpha 1 anti trypsin deficiency. So this cause what? A decrease in elastin protein, and decrease elastin protein means what? Decrease recoil. Okay, so what are the pathophysio? Alpha 1 antitrypsin. Okay, and second cause is, it could be pollution or smoking. Smoking, what? Cigarettes. Okay, some people drink cigarette, cigar also, बीड़ी नहीं रखते, cigarette or cigar. Okay, smoking. Okay, so now what happens is smoking will also cause, smoking cause century acinar, emphysema, and elastin deficiency. It causes which one? It causes pan acinar. Pan acinar. What is pan? Means entire acinus is enlarged. Entire acini. Centri means the middle part. Okay, central part. Okay, so it is entire acinus, it is the central part. Now how do you remember? So use a simple trick. Okay, cigarette, centri. So cigarette smoking centri. Okay, so cigarette smoking centri. And trypsin, pan acinar. So trypsin, enzyme damage is everywhere, smoke is mainly in the airway, so that is why you can remember centri is the central part, that is smoking. And if entire, it is deficiency of enzyme everywhere, that is pan acinar. So pan, papa और सासा, पापा सासा. तो सिगरेट पियोगे तो सेंट्री. ओके, सिगरेट. और अगर एम्फाइजीमा है कौन सा? पैन. दिस. ओके, हाँ, मोस्ट कॉमन माइक्रोस्कोपिक इज इरेगुलर. ओके, सो रिमेंबर, वैसे बुक्स हैव गिवन it is the most common variant. So if nothing is mentioned, you take this as most common. Microscopically, if they ask you, most common irregular. So microscopically, most common, it is irregular variant. Again, in pathology, bit confusion, but I am sorting it out for you. So are you clear? That's the case. Okay, so emphysema is covered. Okay, now in emphysema, what is the problem? Because of high compliance, air can come and it is there, dilated. But because of poor recall, the air cannot go out. So air will keep accumulating and cause dilatation. So therefore, write a statement. So what is happening in emphysema? So in emphysema, due to poor recoil, the air which came in inspiration, the air which came in inspiration can't go out, can't come out, go out in expiration. Okay, why? Because there is a poor expiration. So the result, it causes air trapping. Okay, so it causes air to be trapped. So air trapping. Are you clear? So air trapping occur. Okay, so air trapping occur. Okay, now as there is air trapping, it causes what? It causes increased size of the thorax. So it causes what? First, it causes hyper inflated lungs. So the very important, if you see everything dark, so therefore you see very dark X-ray with chest also bulging and diaphragm pushed downward. Normally diaphragm is what? Till 6th intercostal space. Now you can see it to 8 or 10. So that's why you see a downward movement of diaphragm. So hyperinflated lungs. Okay, and also barrel chest. Sorry, barrel chest. So we see hyperinflated lungs and barrel chest, and patient is having dyspnea, suffocation. He is hyperventilating. Okay, with fish, या pursed lip breathing. So pursed lip breathing and pink puffers. So remember this. So patient is hyper and the lips are sealed closed, like so. His lips are like a purse. Have you seen a purse? The purse is closed. So pursed lip breathing. Okay, and there's a pink puffer. Okay, So pink puffer. Okay, so what are the three feature? Hyperventilating, pursed lip breathing, and pink puffer. Face is completely red and he is breathing very forcefully. Okay, clear? So let me show you all the features. Okay, so let's see them. Okay, fine. Okay, so first is, let me show. See, so this is pursed lip breathing. Can you see? The lips are closed, sealed closed, as if it's a purse. She's not kissing you. Okay, do you want a kiss from her? No, no. Okay, some people say bad. Okay, so can you see this? This is the classical pursed lip breathing. Can you see? So they make the lips come very close and then they will breathe. So that is called what? Pursed lip breathing. Okay, clear? Pursed lip breathing. Okay, fine, fine. This is the case. Okay, this is the case. Okay, so can you see pursed lip breathing? Okay, then next is, you will see them as pink puffers because they are huffing and puffing all the time. Okay, blue bloater is a bronchitis. Okay, so they are, so he's a pink puffer, he's a blue bloater. Okay, clear? Fine. Okay, and finally barrel chest. See the x-ray. Okay, so you can see first is what? You can see the first, this is a very big expanded lung fields and the diaphragm is pushed much downward. Okay, clear? So you can see, plus you can also see some bulla formation is not seen much here. Okay, clear? Yes, this is better. Okay, this is normal. Okay, can you see? This is the, yes, very dark fields which you are observing here. Okay, and barrel chest, let's see. Okay, so the chest become like a drum. Can you see? This is normal chest, scaphoid. It is called as scaphoid. So normal chest, it is called as scaphoid shape. Okay, scaphoid. Okay, like a boat. Now it become like a what? Like a drum. This drum is called as barrel. Okay, so what is barrel chest? It is drum shaped chest. Drum shaped chest. Okay, fine. Drum shaped chest. Okay, chalo. So I think it's seen by all of you. Okay, chalo. So we'll start now. So learned about this emphysema. Okay, now question is, what is the summary? So let me give a summary. Okay, compliance. It can be either increase, decrease, or normal. Normal is healthy lung, increase emphysema, decrease in what disease? It is in RLD. So restrictive lung disease, the compliance is decrease. So restrictive lung disease, the compliance is decrease. Okay, fine. Now problem can be in compliance, yes, and we can measure. Okay, what is the formula of compliance? So let's say formula. Of compliance is delta V by delta P. So the formula delta V by delta P. Okay, now what does delta means? Delta is change. Okay, clear? Okay, now is it clear? Okay, now let me teach it in a simple way so that you never make a mistake. Okay, let's say this is a lung and it has X volume, X pressure. Okay, now what you do is, doctors, you put some air. Okay, so you insert some air. Okay, so as you put the air, the molecules are going to come inside and the pressure is going to change. So let's say you give what pressure? Let's say we give delta P 1 mmHg. So how much molecules you give which are creating a pressure of 1? So as you create pressure of 1, it will expand the lungs. Obviously it will expand the lungs. So lung size is obviously going to increase. So the increase in the size. So now let's say the size increase to, let's say it was 1000, now it is 1200. So that is 200 increase, 200 ml increase. That is delta V. So earlier it was having a volume of, let's say, I'll give example, let's say volume, okay, was 1000 ml. Now after 1 mmHg pressure, the volume is 1200. So what is the delta V? So delta V is 200 ml. So that means a 1 mmHg pressure change created a volume change of 200. Are you clear now? So what is the compliance? Is compliance. It is clear? So I hope it's clear. So 200 ml by 1 mmHg. Clear? So let's start. Okay, so delta V and delta P, that is 1 mmHg. Okay, so that means the compliance is what? 200 ml per mmHg. So in simple language, if I give a pressure of 1, the chest will expand by 200. If I give 2 pressure, chest will expand by 4. So I know the relation between pressure and volume. So that means how much stretching is produced by pressure force of 1? Answer is 200. So that is what the compliance is. So don't go in mathematics, just understand that if you give some pressure, the volume will change. How much pressure cause how much volume is called as compliance. Okay, so just remember one final thing. Let's say normal lung compliance, let's say it's 200 ml. I'm just saying mmHg. So let's say it's normal. Okay, 200. Okay, now I will give a scenario. There are 2 people, person A, person B, a patient A or patient B. I record their compliance. One is 100 ml per mmHg, other is 300 ml per mmHg. Easy. So what are the compliance values? It is 100 ml and yes, it is which one? Yes, it is 300 ml. Okay, so 100 and 300 ml are the values. Okay, now I have a question. Person A, when you give a pressure of 1, it's expanding to a value of 200 or 100? 100. That means less volume means less expansion, less stretching. So what is the meaning? There is a low compliance, less compliance. Example, which disease? RLD. So RLD, so easy. So RLD, there is a low compliance. So RLD, there is a low compliance. In this person, there is 300. There is 300. That is higher volume. So that means it has a high compliance. Means this person lung are inflated so easily. So take 2 balloon, a very very thick balloon and very thin. So you blow the air. One balloon flow easily. The higher compliance. One doesn't inflate properly. That is poor. So it is having a yes, high or low. So it is a high compliance. Example, emphysema. Example is emphysema. So I hope it is easy now. So this is emphysema. This is emphysema for you. Okay. So let me summarize everything. See, this is a lung. Okay. This is the lung. Now in this lung, let's say a normal person is inflating and the size increases to this 200. Now look at this one. Okay. This red one is, let's say, inflating up to this much. So can you see he's inflating same or less? 100 ml. So obviously he's inflating only 100 ml. So is what normal or reduced? Reduced compliance, RLD. On the other hand, this green one is inflating 300, which is normal or more than normal? 300. It is emphysema. ज़्यादा फूल गया ना? So emphysema, too much fooling, flow, fill here. So emphysema is inflated lung, too much inflated. Clear? And in this case, it will be less. Okay. In this, it depends on where are you measuring. If you are measuring in the blood, this hypoxia will be reduced. But in the lung, there is dead space. So in the lungs, it is high partial pressure. Okay. Fine. Okay. So are you clear? Okay. Then we see about the obstruction. There are disease called as obstructive lung disease, OLD, that is obstructive. Now we can divide them into two categories. What are the two categories? On the basis of a test called as beta 2 agonist test. Okay. So what do you do? We will give salbutamol, salmeterol. Okay. Now what happens? If there is only a bronchospasm, it will be relief. So if there is a very good response, the wheezing disappear and the breathing become normal. Good response. Okay. Good response. This is called as reversible obstruction. So are you clear? So the name given reversible. Why? Because the problem was airway narrowing. When you give reverse, it's called what? Reversible obstruction. Example, bronchial asthma. So which is a reversible obstruction? Yes. Why? Because it causes bronchodilation, and that's why there is a good response and the patient is relieved of sign symptom. So bronchodilation. But if you get a poor response, we know the problem is something else. So if there is a poor response, we know the problem is something else, and the problem is what? Irreversible obstruction. And this irreversible obstruction is most commonly seen in the COPD. That is example COPD, chronic obstructive pulmonary disease. Okay, chronic. Okay. Now they are of two types. Okay. So they are basically of what types? They are basically of two different types. Okay. So what are the types in this both the conditions? Okay. Clear? Either it is chronic bronchitis or it is emphysema, I hope it's clear. So it is emphysema in this case. Okay. Now chronic bronchitis is also called as blue bloaters. Emphysema is pink puffers. So how to remember? Use my technique. See, ba, ba, ba. So it is ba, 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 ba. So bronchitis, blue bloater. Bronchitis, blue bloater. Emphysema, pa, pa, pa. Emphysema, pa, pa, pa. Pink puffer. So what is emphysema code or mnemonic? It is pa, 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 pa. So remember, ba, ba, ba is bronchitis, blue bloaters. Emphysema are pink puffers. They are pink puffer. Okay, so mostly they are having cyanosis, blue. Cyanosis is there, mainly lips cyanosis, and they are obese. Clear? They are having polycythemia, so that's why they are having pink lips. Okay, also polycythemia, too much RBC, and they are thin. So this is the classical description of emphysema patient. and bronchitis. Okay, so bronchitis are blue, cyanosis, so they have blue lips. Okay, and they are mostly obese. तो याद रखना this. Okay, and emphysema are pink puffers. Okay, and what the most common thing in COPD is smoking. Okay, smoking and cough with sputum. So lots of cough, lots of sputum and smoking are very common feature of COPD. Clear? In chronic bronchitis, again we have some criteria like Reed index, etc. So we'll see them in medicine, not now, otherwise it will be too long a discussion to finish. Okay, so easy, ba 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 and pa pa pa, and he is having polycythemia and thin, he is obese and having cyanosis. So I've discussed already, so let me show once again. Okay, so pink puffer and blue bloaters. Okay, so we can see it here also. Okay, oh, they are opening some. Okay, so what do you see? This is blue bloater, he is obese, smoking, and he is having what? Blue color. This is what? Excessive dark fields, diaphragm is pushed downward, and he is what? He is a pink puffer. Okay, so he is pink puffer. Okay, clear? So it's emphysema. Okay, hypertrophic lungs, flattened diaphragm because of diaphragm is pushed downward by the air, and that is the finding. Okay, clear? So severe dyspnea, pursed lip breathing. Can you see the lips? They are very close, so pursed lip breathing. Okay, fine. Okay, so diagnostic criteria for bronchitis is what? 2 years consecutive cough with sputum more than 3 months. Okay, so the criteria, plus we use GOLD criteria for their differentiation. Okay, clear? GOLD. Okay, they are all parts of medicine. Abhi, that is more than sufficient. Okay, fine. Okay, and don't look at that girl, who's this girl, etc. I don't know, I just got this from internet. Okay, chalo. Okay, clear? Fine. So you can see this classical picture I discussed already. Again it is the pink puffer and blue, again very commonly asked in the exam, and this is very important. Okay, and what is the GOLD classification based on? This basically based on FeV1 percentage. So you can write one thing. Okay, so what do you use for COPD? GOLD. GOLD for COPD, also called as COLD sometimes. COLD. What is COLD? Chronic obstructive lung disease. So sometimes they can use the word lung also, that become cold. So what is the mnemonic we used to learn? GOLD for cold, GOLD for cold, GOLD for. So global obstructive lung disease classification is GOLD, standard for that. Okay, clear? Fine, done. So GOLD for cold, GOLD for cold. What is the criteria? FeV1 percentage, and I'll make it easy for you to remember. 80%, 50%, 35, 20. Easy हो गया. 80, 50, 35, 20. That's it. Mild, moderate, severe. चलिए बाद में करेंगे. Okay. Now we see the spirometry to diagnose all this investigation. Okay. So I think you have now understood what I am trying to do. So that is why the idea is try to solve as many questions. So when you go to patho class, the sir will revise you emphysema, alpha nitripsin, types of, you will say, oh, we already know them. Then you go to medicine class, they will say the most common variant this, oh, we know them. So that's why by the time you go to medicine, toward the end of the session, that is around October, November, you will be having which classes? Medicine. That time you will be so happy because now you are just revising. You can see the X-ray now. You can see the pathology slide, you can see histopath, and you say yes. Now only thing is what treatment part is required, and obviously we give steroids, antibiotics, etc. in this case because of infections. I hope it's clear. So patho, physio, all are integrated. That's why the name of the group is also integrated learning, because we are trying to, yes, merge all the subjects into 3 main: medicine, surgery, gynae ops. Peds become a part of medicine only, so all will be clubbed for next pattern. So we already were doing for next pattern. तो डरने की जरूरत नहीं है बच्चों, क्वेश्चन वही आएंगे जो आपको पढ़ा रहे हैं. ओके, ओनली थिंग इज you should be prepared. Okay, if they're giving a patient is smoker, he's smoking for a large amount of time, okay, he's having severe dyspnea and he's having cyanosis. Now the moment he says smoking and cyanosis, smoking plus cyanosis, what comes to your brain? Asthma or this bronchitis? So you know it is COPD, bronchitis. So you know it's bronchitis. If they say smoking with pursed lip, barrel chest, the answer becomes COPD, but this time emphysema. So that's what you smart doctors are. You can solve any possible question. So no need to worry, sir कैसे करेंगे, एग्जाम टफ आ रहा है, अरे कौन फेल करेगा आपको? If you know the facts, no one can fail you. Clear? You have to be smart to solve all possible questions. Are you clear? Fine. So चलो, okay. So we'll take a break, okay, clear? 15 minutes break, then we'll start the last session, that is pyrometry, okay, and tomorrow we'll finish the physiology, respiration, and start with CVS, okay, because I have to finish all the systems and start with the revision part, okay, fine, yes, so 15 minutes break, okay. Take tea, because my mom is making tea, so she just made a gesture कि चाय बन गई है बेटा पी ले, तो मैंने कहा ठीक है. अगर माँ ने बोला ब्रेक दे दो तो यू हैव टू गिव द ब्रेक, ओके. व्हेन मदर से ब्रेक इट इज ब्रेक, ओके. सो माय मॉम कॉल्ड मी फॉर टी ब्रेक, दैट्स व्हाई आई गिव, अदरवाइज यू नो आई वुड हैव परसिड, ओके. सो क्लियर, लेट्स मीट, ओके. Okay, so we are starting the last session now. Break is over. We have started. Okay. Okay. चलो भाई, we'll start. चलो, we are starting. Done. Okay. So I hope you all are, yes, learning the way we are going on. Okay. So those who are already know my notes and my way of teaching, okay, they have now realized ki there is very small distance between physio and medicine. Okay, and this small gap, okay, it can be filled any time you want. Okay, clear? So that's why those who have already read my physio notes, they will not take any problem shifting to medicine. They just need to know some basic other concept like pathopharma, and their medicine is already covered. And this medicine which had almost 70 80 MCQs. Okay, clear? So that means in future also medicine will carry bulk of the questions. So that is what we are trying to do, become good in medicine, so that whatever pattern by देंगे तो question patient से ही, ऐसा तो नहीं है they will give from air, so we will be able to solve them comfortably. Okay, चलो, now we'll discuss very important topic, that is spirometry. Spirometry. Okay, now it's a part of what? It's a part of PFT. PFT. Okay, what is PFT? Pulmonary function testing. Pulmonary function testing. Okay, So PFT is part of pulmonary function testing. Now, whenever you suspect a patient of lung disease, okay, you will do investigation like CT, MRI, X-ray, and the functional this is cannot be done by X-ray. X-ray is for structural, CT, MRI is structural. For function you do PFT. So if you want to say anatomical structure, for structure you have this X-ray, maybe ultrasound, CT, MRI. They are anatomical things. For them you need to be good in anatomy to understand the findings, okay. But PFT is a functional. That's why PFT is taught in, yes, not this physiology class, but it's taught in physiology, not in this, okay. So therefore X-ray, etc., and they both are a part of medicine. So therefore whenever possible I'll keep giving you idea of CT, MRI also the physiological function, okay, PFT. Now question is, how do you do the pulmonary function testing? So question is how. Answer is a machine called as spirometer. Now what does it do? It records inspiratory and expiratory lung volumes and capacities. Okay, so inspiratory and expiratory lung volumes and capacities. Are you clear? So both inspiratory and. Now let me first explain the basic concept so they don't make a blunder in basic concepts. Clinical will come later, okay. See, first basics, then clinical, okay. So first is understand record. That's why what meter. What does meter means? Recording instrument. So that's why it's an instrument for recording. Why is it called as spiro? Because it records inspiratory and expiratory. That's why word is spire. So the spire means inspiratory and expiratory. So when you take the air in, it is inspiratory volume. When you expire, it is expiratory, okay. Now what is volume and capacity? Volume is any value, 100, 200, 300. Capacity is defined as sum of two or more volumes. So when you add two or more than two volumes, the sum is called as capacities, okay. So sum of two or more volumes is what? It is capacities, okay. So it is capacities. Are you clear? Okay, so it is capacity, okay. So are you clear to this point? Okay. Now let's see what the principle. Principle is simple. The device is, let's say, bottle, okay. So if I drink water from the bottle, the water level will decrease and I can know how much I drink by checking the remaining water. Or if I vomit or urinate, okay, don't think, okay, कि करके दिखाऊंगा, okay, मैं क्यों करके ऐसी गंदी चीज, okay. So let's say I vomit, okay, in the bottle, okay, don't imagine, okay, dirty people, or pass urine in the bottle, so the volume will rise. So that is how you know person's urine volume, daily urine volume, okay, clear. So that is the idea about the same. So when you take the air from the machine or give air in the machine will calculate the volume. But that also means if a air never enter the lung or never leave the lung, it will not be measured. So that's why problem is, okay, it can't measure the air. So it can't measure the air not coming out of lungs. Out of lungs. Example, yes, RV. So RV is measurable? No, 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 no. So RV is not measurable. By which investigation? The answer is spirometer failed to measure the RV. Are you clear? So it can't measure the RV. Are you clear? So can't measure the RV, okay. Why? Because RV never comes out. Why? I'll discuss later, okay. Now we'll see normal lung volumes. Normal lung volumes, okay. So please understand what is the funda about the normal lung volumes, okay. So first we have is TB. That is tidal volume. Normal is 500 ml, half liter. So what does tidal means? Okay, so first is when you take a breathing, it look like a tides. Okay, and each tide is equal to 500 ml. Okay, so let me write the definition. It is air going in, that is inspired, and then out of lungs. So it is the air which is going in and then out of lungs in one breath. In one breath. Are you clear? In one breath. Okay. During normal respiration. During normal tidal respiration. Okay. So normal tidal respiration. So I hope it's clear. So is it clear? So normal tidal respiration. Okay, now let me explain it in a easy manner. So first is TV is normal inspiration also. So what is the normal inspiratory volume? TV. And what is the normal expiratory volume? It is also TV. So technically TV is one volume, two values, means rather two volumes, one value. Okay. So what is the normal inspiration? TV. Normal expiration? TV. Are you clear? So TV is normal. So let me show it. Okay. And this is like this. So can you see this graph? So this is, let me zoom in. This is inspiration I. This is expiration E, and this is the end of inspiration, and this is the end of expiration. Okay, clear? End of expiration or rest. Why? Because when you finish the expiration, you are at resting position. So this is the resting position, inspiration, expiration, and again you are at rest. Okay. So what is this volume? So this volume from top to bottom is TV. Easy. So TV is one or two volumes. It is technically two volumes, inspiratory also and expiratory. Okay. Now in exercise, you people need only this much air or more air. So obviously we need more air. So can we breathe only 500 ml or more? So we can breathe almost 5-6 times extra. So ask him to take a very deep breath. So this is maximum inspiration. Maximum inspiration. So this air is IRV. IRV. So what is the second value? Inspiratory reserve volume. Inspiratory reserve volume. Okay. What is the normal value? So normally it is 3 liters. Okay. 3 liters. Okay. Short form IRV. Okay. Please copy IRV. Definition. It is maximum inspiration above tidal volume. So why it is not tidal volume? Because tidal volume is normal inspiration and it is extra inspiration. So always remember it's a extra inspiration, not a normal. So if you want to remember it as extra inspiration. You will never make a mistake. So what is the extra inspiration? It is IRV. What is normal inspiration? TV. So normal inspiration is TV. Extra inspiration IRV. Extra IRV. Okay. By same logic, can you people expire only 500 ml or more? That is ERV. ERV. That is expiratory reserve volume. Okay. Expiratory reserve volume. Okay. Clear? So I hope it's clear. expiratory reserve. Okay, now definition, it is maximum forceful expiration after normal expiration, that is after TB. Okay, normal expiration. Okay, so understand, see, so this is what thing, this is normal expiration. Okay, okay, this is ERV. Clear? Fine. So this is normal expiration and this is ERV. This is ERV. So understand? So it is ERV. It is maximum forceful expiration after normal expiration. So it's normal, this is extra. So what is the value? It is around 1.3 liter. 1.3 liters. Are you clear? So 1.3 liter is the value. Okay, so how much? 1.3 liters. Okay, done. Now question is how to remember these three. Forget this, just remember a very simple thing. Make this graph and remember. That's it. So how to remember? I'll make it easy. Make a line like this. So you can see this. Okay, now this is TB, this is IRV and this is ERV. Easy. So TB, IRV, ERV, that's it. So that will cover almost every possible required point here. Okay, clear? One second. Okay. Done? So now after ERV, that is, I do like this. If I do a forceful expiration, what is ERV's? Forceful expiration. So ERV is forceful expiration. So after ERV, that is forceful expiration. Okay, so after ERV, that is forceful expiration. Okay, what is the case? Okay, air will all come out and your lung will collapse? No. आप कितना भी दम लगा लो, कुछ चीजें कभी बाहर नहीं आती, ठीक है? You can apply as much force as you want, but some things are always left behind. Yes or no? Like toothpaste. Okay, you can apply as much force, some paste is always left behind. Yes or no? Clear? So same concept is here also. Okay, like even after breakup, some feelings are still left. Yes or no? So same way, even after ERV, some air is still left. Okay, so what happens? Okay, even after that, some air is still left. Okay, and this air is called as our fourth value, that is RV. Residual. सही है ना? So residual feelings है ना? So residual volume. Okay, RV. तो ये कभी नहीं जाती बच्चों, ये हमेशा रह जाती है. Okay. And after alcohol they increase. Remember? Okay. So residual volume. Okay. Clear? Okay. See, good thing is my mom doesn't understand English. Okay. So if I say something in English, she will not understand. Okay. That's why I can talk about all these things. Okay. Very easily in the class. Otherwise, if she hear me, she will again give me a lesson on how to teach with proper etiquettes in the class. Okay, fine. So residual volume is the case. Okay, what is the definition? Okay, so first it is 1.2 liters. It is air left in lungs even after maximum forceful expiration. Okay, in simple language, it will never ever come out. So never ever come out. Which air? The answer is residual air. Okay, fine. Done? Now comes the question. The question is, what is the reason it is not coming out? The answer is, right? Okay. So answer is, because when you do a forceful expiration, it collapses the small airway, so air get trapped. So reason, okay, during forceful expiration, high pressure closes small airways, so air gets trapped. Okay, so therefore the RV will not come out. Easy, so easy. So during forceful expiration, high pressure closes small airways, so air gets trapped. And if air gets trapped, what happens? This air will not come out. So therefore two things occur. First, RV is not given by spirometer because not coming out. अब आएगी तभी तो चलेगा ना, है कि नहीं? If someone never come to you, how will you know कि what is the disease they are having? So if a patient never comes to you, do you know what is the disease? No, na. So RV is not given by spiro. Okay, so it is not given by spiro. Okay, clear? Number two, okay, so RV is not given by what thing? By spiro. Okay, number two, if RV comes out, the lung will collapse, so that's why it prevent lung collapse. So it prevent the what? Collapse of the lung. So what prevent the lung collapse? Yes, prevent the lung collapse by the RV. Okay, so prevent lung collapse during forceful expiration. So are you clear? So during forceful expiration, so lungs will never ever collapse. Okay, so that's what the power of RV is. So remember, high forceful expiration will not let the RV come out of the lungs. Okay, now we see the next point is capacities. Okay, capacities. Okay, so what are the important capacities and how do these capacities work? Okay, so first is IC, inspiratory capacity. Okay, definition, just remember formula, no need to remember definition. Okay, it is basically total inspiration. Okay, so it is maximum inspiration including TV. That's it. Okay, including TV. Okay, so maximum inspiration including TV. So the formula of IC, IRV is max plus TV. Okay, so IRV plus TV. So IRV plus TV. Okay, normal value, yes, around 3 to 3.5 liter. 3 liter is IRV, half is this, so 3 to 3.5. Okay, done. Okay, now comes the question. What is the other counterpart? EC. EC is expiratory capacity. Expiratory, it is maximum expiration including TV. So what is the formula of the EC? It is ERV plus TV. So value will be obviously somewhere 1.8 to 2 liter. 1.8 to 2, yes. Okay, so IRV is TV plus IRV, IC, sorry, and EC is what? It is ERV plus TV. Okay, ERV plus TV. So done the two capacities. Third is FRC. Write the definition: functional residual capacity. So what is FRC? Functional residual capacity. So please pay attention, understand the name and definition. It is air left in lungs after normal expiration or at rest. Okay, so once again, it is air left in lungs after normal expiration or at rest, okay, fine. So pay attention, the name itself give the hint. Okay, first, why is it called as residual? Because the air which is coming out or left beside is the air which is left in the lung. So residual means left, okay. Now what is the meaning of the word capacity? You know, it is sum of two. Why? Because after normal expiration. So I'll give idea. Okay, I am sitting at rest. When I do a forceful, what happens? The air comes out, clear, and that air is ARV. And what is the air left? RV is left. Okay, but if I don't do forceful, ERV will not come out. So we know this thing. Why? Because we know, okay, ERV comes out if forceful expiration, but if normal expiration, ERV would stay in lungs along with RV. So please pay attention. Bit tricky thing. So when I do a forceful, please pay attention to me. Okay, clear? So when I do a forceful, what is the air coming out? ERV. And what is left in my lung? Answer is RV. What is left in my lung? RV. But if I do normal expiration, TV comes out. So now ERV is in the lung along with what? Along with the, which one? Along with the, yes, RV. So that means technically FRC is equal to ERV plus RV. That is 2.5 liter. That is 2.5 liter. So 2.5 liter. So let me teach it in a simplified manner. If you can remember, let's say this is a thorax. Okay, thorax, and this is, let's say, airway and the alveoli. Can you see it? Okay. Now what is the air right now? It is ERV and RV. Okay, at rest. Okay, ERV and RV. Now when you do forceful expiration, what happens? There's a high pressure. Okay, so let's now copy this. So now let's see forceful expiration. The ITP rises, which I discussed already, plus 30 mmHg. So now the ITP is plus 30. Okay, so this will put pressure everywhere, and as the pressure is put, the ERV start coming out. Are you clear? So ERV is out. ERV. So ERV is out. What is the only air left? RV is left. Are you clear? So ERV is out and only RV is left, and the alveoli will become smaller like this, and the airway close. I told you high pressure closes, so this RV cannot come out. This RV get trapped. Remember, so RV get trapped and the ERV is out. So at rest, your lung contain what? Two air, ERV and RV. Okay, in forceful, ERV goes out and RV is left behind. At rest, ERV, RV both are in the lung. Easy? So I hope all of you are able to understand. This is what we teach in PG, that why the RV never comes, because there is a closure of airway. High pressure collapse the airway, so air cannot come. And what is this air called as? RV. What is out of the lung? This is RV. Okay, this is a lung. Okay, lung, this is the thorax. Okay, so what is coming out? ERV. What is not coming out? RV. Okay, done. So what is the air in the lung at rest? The answer is what is the air in the lung at rest? Answer is, it is the sum of two, ERV and RV, that is FRC. Easy. So one more thing to remember, people always forget, so I keep mentioning. Okay, so air left after forceful expiration, after normal expiration. So once again, air left after forceful expiration and air left after normal expiration. So what is the after forceful? It is RV. After normal, it is FRC. And if anyone forget, remember a very simple technique. See, everything is same. Only difference is in the word F. If there is a F in the name, there is no F in definition. And if there is F in the definition, there is no F in the term. Okay, so that means there are what, double F, only one F, only one F. Okay, तो एक ही F होता है भाई, बार बार F क्यों होगा? एक बार हो गया F लाइफ में ना. So that's why you only get F once, not multiple times like MCI is doing with us. Okay, so F. So if F is there in the definition, that is forceful. The definition is, what is the air? RV. But if there is F in the name of the value, then definition is without forceful. Are you clear? So now you will never make a mistake. After forceful expiration, it is not FRC. And after normal, it cannot be RV. So easy. So what is after normal? It is FRC. After forceful, it is RV. No 2F, only 1F. Okay, double F not allowed. Okay, easy. Okay, no double meaning talks. Okay, clear? I am not doing double meaning talks. Okay, chalo. Now question is, what is the air in the lung at rest? So answer is FRC. So air in lungs at rest is FRC. And also air in the lungs, okay, in lungs, okay, when IAP is 0 and ITP is -2, again FRC. Are you clear? So this is again equal to what? FRC. Okay, equal to FRC. So FRC is our main criteria or concept. Are you clear? So main criteria. Okay, fine. And one more thing is, the lungs want to recoil and collapse, chest want to expand. So where are these two forces getting balanced? At rest. Remember, at rest means at FRC. What happens? The inward recoil of lungs is equal. So inward recoil of lung is equal and opposite to chest wall, chest recoil. Okay, so they are exactly equal. So lung recoil and the thorax recoil, remember diagram, which one? ITP diagram, they are equal. If you want to make the diagram, this one. So lungs are recoiling inwards and chest wall is trying to move outward. Sorry, I should make here. Okay, so got the idea? So this diagram we have made already, that these two pressures are balanced. Okay, chalo. Now can you measure FRC by spirometer? No. Why? Because RV will not come out, so only ERV will come. So that's why spirometer fail to give FRC as RV won't come out. So that is why what we do, we add a gas in the lung and measure the volume of FRC with the help of that gas. So that's why we use what method? We use gas method. So that is why what we do, we add some gas to measure the volume, and that is why FRC estimation given by, okay, it was asked in AIMS also, last year. I don't know why it was not asked this year in the exam, because this was a very unexpected paper, but this will come once they go back to the previous pattern. So one is helium dilution method. So the first method, helium dilution method is the first method. So helium dilution method. Second is single breath nitrogen wash out or Fowler's method. Okay, now Fowler's method also is used for dead space. Okay, also dead space and closing volume. So they ask you what is the technique for dead space and the closing volume. The answer is, it is given by Fowler's. What is Fowler's method? Nitrogen method. Okay, second is helium method. Okay, second is helium. Okay, good thing is they will not ask you the formulas, because one thing is clear, even this time they never gave you any calculations as such. Are you clear? Yes, they ask the definition or which formula or which technique will be used, like we'll use ANOVA, chi-square, but they never gave any actual calculation to calculate the value. So that's why they will not ask you the calculation. You can skip that part. Are you clear? Okay, now that is clear. Okay, fine. Now in case of obstructive diseases, these two methods can be wrong because there is a airway blockade. So that's why if obstructive conditions, write down, in OLD FRC is given by plethysmography. Easy. So plethysmography is the technique we will use for the calculation of the FRC, plethysmography. Are you clear? So plethysmography. Okay, done. Okay, so this is TLC done. Okay, now we see the fourth and the most important value, number 4, that is VC. What is VC? Vital capacity. Okay, vital capacity. So VC is vital capacity. Definition as the name, vital means what? All. It is maximum inspiration followed by maximum expiration. So what do you ask the person to do? First do maximum inspiration, then do maximum expiration. तो क्या है, पहले खींचो फिर निकालो, not cigarette. Okay, so वैसा नहीं कुछ. Okay, so first take a deep breath and then do deep expiration. So technically you are using which muscle? Inspiratory muscle, expiratory muscle, both. We are using both. So that is why okay, it depend on number 1. Okay, respiratory muscle strength, and number 2 is what? The stretching power of the lung. If lungs cannot stretch, how can they inspire? That is lung compliance. That is lung compliance. So it depends on these two parameters. Are you clear? Respiratory muscle strength and the lung compliance. Okay, now what does it look like? So it looks something like this: inspiration, expiration. This is maximum inspiration, and then this is maximum expiration. Okay, maximum expiration. Okay, maximum expiration. Are you clear? Now, so this value is called as VC. This value is called as the VC. Are you clear? So this value is given which name? It is called as the vital capacity. Are you clear? Clear? Okay. Now understand. What is this value? This value is IRV. So when the person expire from the full lung position or the first air to come out, it will be IRV. And then with effort, the TV will come out. And with further effort, ARV will come out. RV can never come out. So technically, RV won't be coming out. So RV will not come out. So VC is made from which three values? IRV, TV, ERV. So what is the formula of VC? IRV plus ERV. So what is the formula for the vital capacity? It is IRV plus TV plus ERV plus ERV. Okay. What is the normal value? So normal value of this is, right, normal VC, male, female. So males, it will be approximately 4.8 liter, female 3.2 liter. Okay. So male is 4.8, female, and females have lower value because of, so why less? Due to smaller thorax and less muscle mass. Are you clear? Fine. Fine. So less smaller thorax and less muscle mass. Okay. So are you clear? Okay. Now what condition the vital capacity will reduce? So let me explain. So first is VC will decrease in which conditions? I don't know. Physiologically low VC, so physiologically low VC seen in, okay, that is without disease. Okay, so it is seen in the following condition. First, male, female, females. Why? Because of smaller thorax. Then children, again because of small body size. So children, so females, children. What? Old people, बुढ़ाऊ मतलब old age. Then what? Short, चुटकी height के लोग, short, small, short से child. Then pregnant female. What the reason? A pregnant female uterus is big, okay, and it push diaphragm up. Same thing occur in obese person. So obese person is very similar to what? Pregnant. Only thing is this person is pregnant with the fat, not with the baby. Okay. Very bad joke, but again. Obese, okay, and then what? A supine posture. So when I am standing, my diaphragm is going down, so I have more space, but when I lie down, diaphragm goes up, that causes less space. So that is why which posture? Supine posture cause a lower vital capacity. So standing has more VC, supine has less VC. So standing has more VC, supine has less VC. Are you clear? So these are the changes. Okay. So pregnant with baby, pregnant with fat, both have low VC. Are you clear? Okay. Now we'll see disease. It's a very important topic. Now we start the clinical scenario once again. First, VC in diseases. And anything you don't understand, you know what is the solution, you can come to the Telegram group and we will make sure you are understanding, we'll solve questions and I will explain. Okay, and very soon what I plan is we will keep revision sessions. So what is the plan for revision session? Since you are not face to face, okay, so therefore what I plan is in revision I will keep asking you questions and you reply. Like example, I'll start with, okay, in this way, okay, compliance is increase in, so then you give the answer M5. Again I ask, compliance is increase in, you say emphysema. Compliance decrease in, RLD. Compliance decrease in, RLD. Normal tidal volume is, you say. So you can keep your notes with you, like let's say these are the notes you are making, so keep the notes with you, okay, and then I will say and you keep giving the answer, okay. You can see the notes, okay, and keep underlining what I am asking, okay, like what is the most you can say important value, etc., like this, okay. So what is the investigation in case of pleural effusion? We say X-ray. So what is the X-ray position preferred? Lateral decubus. What is the X-ray? Lateral decubus. What is more sensitive? Ultrasound, okay. So we will do this later on, okay, clear, okay. So now we're discussing what? The vital capacity in disease. So there are two diseases, RLD and OLD, okay, fine, okay. So kind strokes respiration will do later when I do abnormal respirations, okay. So kind strokes will do later, okay, clear. So kyphos scoliosis make what? Abnormal chest, na, it's RLD part. So kyphos scoliosis what? Extrinsic RLD, so it will cause what? Low VC. So in this case there is less VC. Why? Answer is simple, due to poor compliance, all volumes and capacities are poor. Clear? Clear? All volumes and capacities are poor, okay. So what is one line summary in restrictive? All values are reduced, all volumes are poor, okay. In obstruction the problem is narrow airway, so lungs are normal, so VC can be normal, so therefore it could be a normal VC, or it could be a, yes, decreased VC due to air trapping. Example, emphysema. Or it could be a normal VC also, like asthma can be normal VC also in the initial parts. So therefore in the initial stage of asthma there is no problem in the lung, so vital capacity is normal. Only thing is because of narrow airway the air comes slow, so therefore what happens? VC might be normal, but due to narrow airways air come much slow like a traffic jam, okay. The air will come fast or slow? The air is going to come very slow, so air comes out very slow, and if the air comes out slow, what is the obvious effect? The air comes out slow, therefore increase time. So I hope I made it easy and clear for you. So what is the problem in the case of obstruction? Is like a traffic jam. So you can take obstruction is like what? Traffic jam. So in a traffic jam the distance remains the same, only time increases and your speed decreases. So what happens? There is a decreased speed, increased time, but distance remains the same. Are you clear? So in a traffic jam there is a decreased speed, increased time taken, and the distance remain the same. Same way in a OLD, again there is a decreased flow rate, there is a increased time, and the vital capacity, that is volume, is same. So you'll never ever forget this now. So what is the comparison? Traffic jam is similar to obstructive lung disease. Speed is slow, flow rate is less, time is increased, and distance, vital capacity remain the same. 4 liter will remain 4 liter, it will not become 2 liter, okay. So what is the one line summary? Vital capacity decrease in which condition? It is decrease in restrictive, almost normal in obstructive. What is the main problem? Time is the main problem in this case. Are you clear? And if you compare them with RLD, normal rate, time is also normal, VC less. easy हो गया ना. So that's why VC is less. So that's why VC is less. Okay, so abnormal graphs. Okay, so I will be doing graph very shortly. So what graphs I'll do all these abnormal breathing graphs, these graphs. So I'll discuss them in the class so that your clinical medicine part is also covered here itself. Okay, chalo, done. So that is why for diagnosis of obstructive lung disease, we have multiple parameters. One of them is asked in the exam and I'll discuss it. So please be very attentive. So therefore, for diagnosis of OLD, time is very important. Time is very important. So I hope I made it clear. So for diagnosis of OLD, time is very important. Okay. Okay. So what is very important? Time. Okay. So time is a criteria. Okay. So that is why we use, hence we use, okay, what investigation? So hence we use, okay, the dynamic volumes and capacities. So dynamic volumes and capacities. I hope it's clear. So what are we using? Dynamic volumes and capacities are being used. So what is the example? Example is TVC. TVC. So what is TVC? Timed, or also called as FVC. Full form is timed or forced vital capacity. So timed or forced vital capacity. Are you clear? So timed or forced vital capacity. Okay. Now what are the meaning, definition? Understand. Okay. Example, it is vital capacity and time taken. So please understand. Okay. If there's a traffic jam, what happens? The volume is almost same, but the time increases na, and the speed decreases. So what happens is, let's say example, 4 liter in 3 seconds. So what is the volume? 4 liter. This is vital capacity. 4 is vital capacity. Okay. And this 3 second, this 3 second is the time. So if there's an obstruction, the time will change. If there's a restriction, volume will change. So that is why you can make diagnosis of both restrictive and obstructive. If volume is less, it is what? It is RLD. And if time is more, or the rate, flow rate, this is the OLD. Are you clear? So this is OLD. And if this normal rate, normal time, but less VC, this is RLD. Are you clear? So this becomes the best method for diagnosing obstructive lung diseases. Are you clear? So obstructive lung disease. Okay. So let's start. Next is, we divide TVC into three parts. Okay. And they are FEV1, FEV2, FEV3. These two are not used, only FEV1 is of use. So full form is forced expiratory volume in first second. Definition, it is air expired at the end of first second of TVC. Okay. So the definition, it is the air expired at the end of first second, okay. And if you remember, it was asked in this year's exam. Are you clear? So it was one of the questions in this year exam. Okay. So 31st August definition was asked. Okay. So I hope, is it clear now? Okay. So was this question there? Definition of FEV1. And I told you it will be 100% exam question. FE1 definition. Ask or not ask? 31st August exam. Diagram I'll teach, don't worry, okay? So is this question clear? Okay. So now what is the normal value for this, and let me teach it in a proper manner, okay? Fine. Okay. So first is, look at this. Can you see this? So this is VC. This is VC. And this is, let's say, time axis. Can you see this? So this is 0 second, first second, second second, third second. Can you see? So this is the air coming in second second, first second. Are you clear? So this is the concept. So first second, second second, third second. Are you clear? So here we start the TVC. So he is now expiring. So air is coming out. Are you clear? So this is the time. So 0 second first. So how much air came in the first second? This is FeV1. So this is FeV1. Okay. So can you see this now? So this is the graph which we can see for the obstruction and restriction diagnosis. Okay. Now if there is a value which is taken, so the normal value, so right, example, let's say TVC is 4 liter, okay, 4 liter, and this is 3 liter. So Fn is 3. So that is why out of 4 liter, how much came in first second? Almost 3 liter. So out of 4 liter vital capacity, how much came in first second? Answer is 3 liter came, okay, and the remaining came in the second, third second, okay. So that means first, second all came? No, only 3 liter came out. Only 3 liter came out. So we can express it as a percentage called as FeV1 percentage is what? It is FeV1 percentage is given as FeV1 by TVC into 100 or the normal value. Normal is 75 to 80%. Okay. Now if there is a obstruction, it will take long time. So therefore in obstruction the graph will become wider and take a long time to finish to the end. So that is will take more time. So therefore in first second less air will come out. So in obstruction there is slow expiration. So OLD, there is slow speed, flow rate. So flow rate is very, very slow. If the flow rate is very, very slow, what happens? There would be reduced FeV1 percentage. So there will be a decrease FeV1 percentage. Are you clear now? So what is decrease? FeV1 percentage is decrease. Okay. And how do you remember? I am teaching a very simple rule to remember. What is that? It is the 80% rule. So less than 80% is mild. Okay, clear? Then we take 50%. Then we take which one? 50%. Okay, clear? Then we take 30%. Are you clear? Easy. So 80, 30. So add 30 plus 50. How much you get? You get. So what is the criteria? 80%, 50%, 30. It is for severity of asthma or COPD. So severity of asthma. Okay. So how do you remember? Very simple. If it is less than 80 but up to 50, it is what? It is mild. If it is 50 to 30, it is, so this is mild obstruction. This is moderate, and less than 30% is severe. So easy. So now will you remember it? So less than 80 but more than 50, up to 50 is mild. Less than 50 but up to 30 is moderate, and less than 30 is severe. What value? FeV1. Easy. So FeV1 percentage is a very important value. So FeV1 is a very important value. So please remember it. Less than 80 is mild obstruction till 50. Less than 50 up to 30 is moderate. So what is it? It is less than 50 up to 30 is moderate. And if you are less than 30, it is severe. It is severe. I hope it's clear. Mild, moderate, severe. So now you know the values also. Okay. In RLD, it will be normal. There is no obstruction. So normal or increase FeV1 percentage. Very important topic. So RLD either normal or there is a increase FeV1. So right, please. Best investigation to differentiate OLD from RLD is FeV1 percentage. Okay, and I kept asking, please study all these things. They will be asked in the exam, but just because medicine no one study and physiology even more ignored, people skip and they only focus on high yielding subjects like what? Gynae, surgery, PSM. Okay, and that was the problem this time. Medicine was huge, physio was huge, directly, indirectly. So that's why please understand. Okay, I know it is difficult to understand this in first instance, but the rewards are much more. The rewards are what? You are able to find the paper logical and we can solve any difficulty question. Okay, and you can pass even. So what do you think? Will people not pass? They will pass and even they will get 20 plus. Okay, so therefore we have to make our concept very strong. Okay, so are you clear with this? Okay, so what is the best investigation? It is FeV1 percentage. Okay, so imagine where people are worried about passing. You people score 200 plus. Will it not boost your confidence? Will it not make you think realistically that I must work even harder to get a PG seat? So that is the idea. Okay, वो क्या कहते हैं मोदी जी भी, आपदा को अवसर में बदलो. क्या है वो? Turn any calamity into opportunity. Okay, so हम भी यही करेंगे. क्या करेंगे? इसको बना लेंगे opportunity. Tough paper, what happen? Two things. Either you give up or you become tougher. Like example, when you start exercising, two things occur. Either your heart fail to pump and your heart goes in failure, or the heart start hypertrophy. So always there are two things. When there is an increased workload, either you become better at that or you just lose. Like example, when we were in school, nursery, KG, LKG, all students used to get what? Good marks, na? All used to get 100%, hai na? And all parents used to think our kid will become doctor, engineer. But when you go to higher classes, hai na? 5th, 6th class, what happened? The difficulty level increase. Okay, you are taught what? Mathematics, all this. Okay, algebra, trigonometry. So some students, they just give up and their performance start falling. 80, 70, 60, and they barely pass 10th class and they are forced to take what? Arts, commerce. But we people kept working hard. So when the syllabus increased, toughness increased, we never gave up. We started working hard and we were able to get 80-90% board and we took science. And then in science also, lots of people drop. They say, I can't study or I can't understand any physics. What is this integration, calculus? But we kept going and we were able to clear 12th board. And then we took medicine. And then in 5-6 year medicine, we kept learning and learning. And if you see books, I don't want to show you, but I had more than 100 textbooks during my MBBS. Okay, for each and everything. Okay, clear? At least 10 books were there in the first year. 7 books in anatomy itself. 7 books. What? Histology separate, neuroanatomy separate, then what book? Embryology book separate, then we had 3 part of BD Charosia, then dissection manual separate. So we had 7-8 books in anatomy, then 2-3 books in physiology, biochemistry, practical books. So that's why what happened, we kept learning and we keep improving our level so that we become one of the best. Okay, clear? And that is what I expect from you, best outcome. Okay, so therefore keep learning and one day you will become perfect in almost each and every aspect. And I really want to see you people crack all the exam, PG exam, AIMS exam, PLAB, USMLE. I want you to laugh at the level of question asked at those exam कि अरे तो बहुत ही easy है, इनको तो हम आराम से कर लेंगे. ठीक है, चलो. So what is the first investigation? FeV1 percentage. So now it gives two different ventures. What is that? Either it is normal or it is decrease. If decrease, it is what? It is OLD. OLD, okay. What is the next investigation? You will do the investigation for types of OLD, okay. So next is we want types of OLD, okay, clear? Okay, fine, yes, okay. So whatever happen, we will keep fighting and you will come out stronger. I know you people are going to perform. Yes, 31st August people, you are going to pass the exam. Prepare for PG, double, triple effort. Those who are giving December, you should continue working, because sometime when you start studying for the first time so much, so long, it's difficult, okay. If normal, I don't know, it might be RLD. So therefore, we record VC. And VC can be 2. Either it is normal or decrease. If decrease VC, it is RLD. If decrease VC, it is RLD. It is RLD, okay. And if it is normal, it is what? His lungs are normal, his airway also normal, he is useless for us, healthy. ये किसी काम का नहीं है, healthy है. So we don't want, sorry, गलत बोल गया. We doctors want everyone to be healthy, but before that they should become ill. We should treat them and then we'll be, yes, making them healthy, okay. So we want everyone to be healthy or we want to make them healthy. Better we make them healthy ना, थोड़ा business आएगा भाई, समझा करो ना. Just joking, okay. So now comes the question, sir, we understood very well, okay, that if F% decrease, it is a OLD, and if normal, we record VC. If VC decrease, it is RLD. Done, done, done. Now, what we know? RLD 2 types. If there is decrease RV, it is intrinsic, and if it is normal RV or increase, it is extrinsic. I told this. Then OLD can be what? Reversible or irreversible. Reversible are asthmas, irreversible are COPD. Now this is one thing. Second is OLD has types of obstruction. So now there are 2 type of obstruction, okay. So I don't 2 type of obstructions. 2 type of obstructions, okay. So what are the 2 types? They are fixed obstructions and variable. So please copy them. So there are 2 kind of obstructions, fixed obstruction and the variable obstructions, okay. So fixed and variable. In fixed, the obstruction is in such manner that both inspiration and expiration are severely affected. So what happens? Both inspiration and expiration are severely affected. Are you clear? So severely. In variable means what? What is variable means? Change. One phase affected more. So one phase affected more. Like in asthma, COPD, what is affected more? Expiration. So example, we have variable intrathoracic obstruction. That is inside the thorax, okay. Intrathoracic obstructions, okay. Here example is small airway affected, okay. Examples asthma, COPD, asthma, and what happens? Expiration affected more. And what is the hallmark? Wheezing. Wheezing. So we get the wheezing in this case, okay. So we get the wheezing in this case, okay. And in case of variable, so I'll use the short form VITO. What is VITO or VITO? Variable intrathoracic obstruction, VITO. So please highlight it. Second is variable extrathoracic. Here basically what is involved? Here basically trachea and bronchi are involved. Trachea, bronchi. Okay, so trachea. Here basically bronchioles, etc. Okay, so trachea and bronchi are involved. Example, subglottic stenosis. subglottic stenosis, okay, or laryngo or tracheomalacia. Okay, even diphtheria, where the pseudomembranes are formed. Again, this question was given, pseudomembranes are seen in diphtheria, okay. So diphtheria. So remember, anything which is above the thorax, this is extrathoracic obstruction, and anything below the thorax, this is what? Inside thorax. So this is intrathoracic, extra. So I'll give an example, okay. This all trachea, bronchi, oropharynx, no, they are all extrathoracic, and this is this, okay. Clear? Diphtheria, okay. This question was again asked, diphtheria, okay. What do you see in diphtheria? Pseudomembranes in oropharynx, okay. Pseudomembranes in oropharynx, and the diagnosis made by, we see what? The Chinese letter, the cuneiform appearance on giving what's stain? I think Albert stain, okay. I don't remember exactly, but I think Albert stain is used for that purpose, okay. Fine. Okay, diphtheria. Now what happens here? The inspiration affected more, and sound is stridor, inspiratory stridor. So that's why wheezing is a marker of variable intrathoracic obstruction, and stridor is a hallmark of extrathoracic obstruction, okay. So it is the case, okay. Fine. So therefore above the glottis is all extrathoracic, below the glottis you might have intra also, okay. Fine. Okay, so it is stridor. Now how do you diagnose? It is whether intrathoracic, extrathoracic, variable or fixed. The answer is, for that we use flow volume curve, flow volume curve, okay. So again it is given by spirometer only, spirometer, okay. So spirometer is used for this particular purpose. What thing? So flow volume curve, we use the spirometer in this case. I hope it's clear, okay. Now how does it work, or it is going to be seen? So understand, first is understand a normal graph. So this axis shows the flow rate, okay, and this is the volume, this is the volume, okay. So flow rate, and this is the volume, okay. This one is plus, like 0, plus 5, plus 10. Unit is liter per second. So basically it is speed, and this is minus 5, minus 10. Why? The answer is simple. When a person inspire, the air is going into lung from the machine, so machine is losing air, and when you expire, machine is gaining air. So that is why the bottom half is inspiration curve and above is expiration curve. Easy. So what is the bottom half? It is inspiration, above is expiration. So inspiration at the bottom, expiration at the top. So let's start the discussion. So first discussion point is, when you inspire, the air comes in. So this is inspiratory graph. Can you see it's like a hemicircle? So this is the inspiratory graph, and when you expire, the air initially come very fast, and as the air come from small airway, because of airway closure, the speed decreases. So this is the graph, okay. So graph of what? Expiration, okay. So this is expiration, okay, and this, okay, and this called what? PEFR, peak expiratory flow rate, and this is PIFR, full form I'll write later. It is peak inspiratory flow rate, and this peak expiratory flow rate, okay. So please remember the shape, and I'll make it easy for you so that you never ever forget. So what is the concept? Remember it like this. Let's say this is a graph, okay. So this boy is having his birthday, okay. So birthday, so can you see the birthday boy? So birthday boy is having a face, okay, and you know all the boys or the birthday boy or girl, their face is always inspiring face. So that means this, okay, and what do they have? They have a cap, and the cap of expectations. क्या भाई, बच्चों से क्या है पेरेंट्स की एक्सपेक्टेशन, माई सन माई डॉटर विल बिकम डॉक्टर, तो क्या है पहाड़, एक्सपेक्टेशन का क्या है, और माउंटेन ऑफ एक्सपेक्टेशन, सो लुक लाइक अ माउंटेन ना, so now you can see it look like a mountain, so it look like what, it look like a mountain. Okay, so mountain of expectation and a inspiring face. Okay, so that means this yellow triangular area is expiration, so yaad rakhna expiration is like a mountain, expiration is like a mountain, and the face inspiring guglu guglu face, साइनोसिस लग रहा है पर ऐसे नहीं, पिंक करेंगे भाई, हम तो पिंक करेंगे, मजा आएगा। पिंकू पिंकू बच्चा हमारा किस कलर में, हाँ ये रहा, और ये बच्चे का फेस है ना, सो व्हाट इज द फेस, इंस्पायरिंग फेस, सो दैट इज व्हाई द फेस इज इंस्पिरेशन, याद रहेगा, विल यू रिमेंबर दिस, सो फेस इज हेमिस्फीयर, हेमिस्फीयर and the expiration is like this. Are you clear? Now what will happen if there's a problem in this, it is which obstruction, extra thoracic, it is extra thoracic. If problem is occurring in the expiration, it is intrathoracic. So this is veto, this is VETO, that is extra thoracic obstruction, this is intrathoracic obstruction. So I'll make the graph and you try to identify, see. Okay, so what is showing a problem, answer is expiration is poor, so there is what, less value of expiration. Okay, so this is poor expiration, so it is fixed or variable, it is variable, so it's a what, it's a variable extra thoracic obstruction, easy, so variable extra thoracic obstruction. Look at this here, problem is where, it is in expiration, so this expiration is poor, so it is poor expiration, it is a, yes, variable intrathoracic obstruction. Example, COPD, asthma, easy, so COPD, asthma, and look at the last one, can you see them? Okay, and last one is this one here, where the problem, both inspiration expiration, so poor, poor expiration, poor, both are poor, it is fixed obstruction, FO, fixed obstruction, FO, not that FO, so FO is fixed. अब बताओ, easy हो गया, so now you will never ever forget this. Okay, it's basically taught in PG, but I have given you, so if there is a intrathoracic obstruction like asthma, you will see a graph with problem above. If it is intrathoracic, this is the case, if extra, this is the case, is extra obstruction, this is intrathoracic obstruction, and if both are affected, it is fixed obstruction. Okay, so I hope it's clear. Okay, so fixed obstruction, intrathoracic, extrathoracic, all are covered. Okay, 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 so let me, sorry, it is inspiration, yes, thank you Kurti. Okay, so yes, diagnosis is correct, but I just made a mistake. Okay, yes, so this is poor inspiration. Okay, this is what, variable extra thoracic. Okay, so let's do a, yes, it is poor inspiration, sorry, so let's do a revision and let's see how many of you are able to identify. तो क्या करना है, लिखना है what is what. Okay, so क्या है options, VITO, VETO. Okay, clear, इसमें COPD याद कर लो. Okay, जिसमें क्या याद करना है आपका, भाई स्ट्राइडर वगैरह, फिर FO फिक्स्ड एंड नॉर्मल. ओके, सो बनाता हूं मैं, आपको बताना है ABC, ABCD. ओके, लेट्स सी हाउ मेनी कैन गिव द राइट आंसर. ओके, चलो भाई, लेट्स सॉल्व दिस क्वेश्चन, देन विल टेक. ओके, फर्स्ट वन कौन सा, फर्स्ट वन करा तो दिया, ठीक भाई, I've correct na expiration inspiration, I just wrote wrong. Okay, chalo do the question. Okay Mudita, we corrected. Okay, so A B C D. आंसर देखो ना क्या पुअर है इसमें. सो आई जस्ट यूज द पेन टू शो प्रॉब्लम और रेड प्रॉब्लम problem no problem. So tell me now diagnosis. Yes, ये तो fixed है, ये तो हो गया clear. This all of you are right, it is fixed. नहीं, this is fixed. This is fixed. This is fixed. Done. Others. First one, inspiration is poor, so it is extra thoracic, it is veto. Here expiration poor, so Y2, COPD, asthma. This is normal. हो गया? So I hope you would all be able. So if you want to write here, so what is Y21? B. What is V21? A. Fix is D. This is C. So now you are at the level of PG people. Even PG people don't know. So you can talk to your friend preparing for AIMS PGI. Do you know the flow volume curve? He say yes, and then you make 3 4 and he will be confused. And if you want to make them very super confused, ये देखो बताना ये क्या है, ये किसका ग्राफ है, ये वाला किसका है बताओ. दिस वन. व्हाट इज दिस ग्राफ ऑफ? किसका है भाई ये? किसका है? आंसर दो आंसर. Very smart people. Okay, so I used to do this in PG class. I'll make this and most will say sir is it restrictive? अरे भाई restriction में ऐसे ग्राफ बनते ही नहीं, restriction में वो ग्राफ हैं. Yes, it is normal. Only thing is axis is reverse. So sometime they will give you graph with axis reverse, but will it change the diagnosis? No, the diagnosis remain the same. So that's why smart people can solve X-ray in both right or left this. Okay, very good. It is normal. It is normal. This is again what? COPD. This is fixed. So that's why it doesn't matter what they give. You are smart people to solve any question, and I'm very proud of you that you are all bang on target. It's a normal. And what is the diagnostic feature? Smiling face, है ना? So smiling face. Okay. So yes, I teach the same manner in PG class also, using funny correlation to make things simpler. So ऊपर cap, नीचे face. Okay. If cap is damaged, it is yes intrathoracic. If face is damaged, it is extra thoracic. Easy. Okay, chalo. So I will finish the class. Okay, fine, and very soon we will have the remaining respiration. So again tomorrow 12 to 8 p.m. we'll have class, and after that 9 p.m. onward we'll do revision of respiration endo. So morning I'll finish around 4 o'clock and I'll start with CVS, and we'll do revision of respi and endo. So B, please go and revise. So what is the homework today? So solve the MCQs, we'll post on the groups, solve MCQs and revise notes. Okay, and tomorrow I'll do revision and if possible keep a test also. Okay, clear? So be smart. Again, there is no point cribbing or crying ki sir do we have to read all this. Is up to you. Okay, either you quit and still hope, pray for passing, or you try to make sure that we are making an effort. There's always two options, give up or continue trying. Okay, I am always trying. Okay, if paper tough, have nothing, they remove me from their institute, I have no job, I'll still keep making effort so that I'm able to do what I am basically born to do, that is help all other people. Okay, so be strong and you are capable. Okay, you are capable of passing any exam. Okay, it's not about FMG exam, it's about passing each and every exam. I want to see you as DM MCH doctors, not just what ki sir exam pass hai life nahi. Clear? No marriage, no nothing. First get a good seat, be a very good doctor, then think about your personal life. Okay, clear? Everyone want to settle down, but will you be happy having a life where your dreams are not fulfilled? Your dream will be fulfilled only when you acquire knowledge to help people. Clear? So that is the case. Okay, so we'll finish today's class very soon, we will see. Okay, chalo by group MCQ are sufficient, I will see. First is please burn one liners. Okay, and old MCQ books, they are not useful because concept तो कुछ है नहीं उसमें, है ना, just क्वेश्चन का आंसर. अरे फायदा ये तो अब ये मैं कैसे पढ़ाऊँ आपको? Do you want me to teach this as MCQ? You will forget. अब आपको ये नहीं पता, क्या नहीं पता, ये मैं बताता हूँ. ठीक है, आपको इनमें से कुछ नहीं पता, घंटा नहीं पता, ये नहीं पता तो ये भी नहीं पता, फिर ऑब्स्ट्रक्शन के अंदर नहीं पता वेरिएबल क्या है ये भी नहीं पता. तो ये बात बताओ यार, कुछ नहीं पता तो बस ये याद करने से बन जाएगा? ऐसे याद करा दिया, ऐसे वीटो का ग्राफ, वाइटो का ग्राफ, नॉर्मल ग्राफ, ये बना लिया, एग्जाम में आ गया सॉल्व. पर अगर मान लो कुछ चेंज कर दिया, कुछ म्यूटेशन परम्यूटेशन आ गया इसके अंदर, देन यू विल बी ट्रैप्ड ना. सो यू कैन नॉट विश दैट समवन विल कम एंड गिव यू ओनली द इंपॉर्टेंट स्टफ एट द एंड. यू हैव टू लर्न फ्रॉम बिगनिंग. ऐसा नहीं होता ना, यू गो टू अ स्कूल, है ना, एंड नेक्स्ट डे यू बिकम अ प्रोफेसर. You have to first learn alphabets, then you have to learn sentence, word, ultimately grammar, then you become a good enough to write, and then you read the English, Hindi, math, science. So please, it's a long journey, so don't rely on old MCQs. What is the right? Okay, study either in the class, okay, or app, whatever. Okay, I don't mind, it's up to you. So study in class, app, okay, and make notes, or if you have old notes, add to the notes, revise, okay, and then MCQs. Okay, and during revision see images, add images. You asking sir what to add? I'll tell you what to add to notes. Add images, without images useless, and clinical scenario, clinical cases. So where will you get all this to modify? ठीक है, if I am taking responsibility, it's my responsibility. So latest pattern MCQ images you will get from the group, and it is my promise, at least you will get 2000 MCQs within next 2-3 months. Okay, now obviously not in a single day, यार बनाने पड़ते हैं भी. 2-3 months you will be, so at least daily we'll have target of 50 MCQ, okay, per day. So what is the target? In 2-3 months we'll cover 2000 MCQ. Okay, so that is the case. Okay, दिवाली पे जला लेना भाई, कोई दिक्कत नहीं. ठीक है, चलो. ओके, सो प्लीज डोंट आस्क मी सर क्या करना, ये प्लान फॉलो करना है. वन लाइनर भाड़ में जाओ, ओल्ड MCQ भाड़ में जाओ. क्लियर? स्टडी फ्रॉम क्लास, ऐप और वट एवर बुक you are using, I don't mind. Make notes, or add to notes. What to add? MCQs and the clinical cases with images, and then that is the target. Okay, chalo bhai, good night, and we will, yes, okay, and आज email करनी है. okay, भूलना नहीं है. ठीक है, क्या करना है? We have to email NBE. Clear? Because only when they get this thousands of email, they will realize the gravity of situation. Okay, so we are trying our level best, asking but MLA, MPs, big principals etc. to call them कि sir we are having someone. Okay, ऐसे बोल के कि भाई मेरे घर में है, मेरा कोई बच्चा, भाई, भतीजा, बहन, वाइफ, सॉरी नॉट वाइफ, घर के अंदर कोई मेंबर है, वो भी FMG है ना, एंड दे आर हैविंग प्रॉब्लम, सो प्लीज हैव अ लुक एट द पेपर. ऐसे करके करा रहे कॉलिंग. ओके, ये बोल बोल के घर के बच्चे परेशान हो रहे हैं. ठीक है, अब ऐसा ना बोलेंगे प्लीज लुक एट दिस. ओके, घर की बात. ठीक है, सो ईमेल टू NB. ओके, चलो, गुड नाइट, टेक केयर, बाय बाय. ठीक है, टुमारो आ जाना. ठीक है, डोंट मिस टुमारोज क्लास. ओके. और सीवीएस चालू हो रहा है, सीवीएस में सबकी वैसे ही समझ गए ना, स्पिंटर टाइट होता है. सो प्लीज कम, टुमारो विल लर्न रिमेनिंग रेसिपी एंड सीवीएस. ओके, सो टुमारो 12 ऑनवर्ड्स. चलो. ग्रुप का लिंक नहीं है आपके पास, कैसा हो सकता है यार? सबसे फेमस ग्रुप है अभी हमारा, है ना? सही कह रहा हूं? आई थिंक देयर इज नॉट अ सिंगल पर्सन who doesn't know about this group, so that's why I'm saying, okay, integrated learning group. So that's why I want all of you here. Okay, बताया तो है 12 PM onwards. Okay, tomorrow क्या है? 9 September. ठीक है? 9 September. Okay, timing is 8 onwards. Okay. चलो, Snehal, the link is his t.me integrate. You just type integrated, you will get my photo and that photo is a mark कि this is a original group. Okay. अच्छा, NB वाला, अरे टेंशन ना लो. NB का आई एम गिविंग यू द ईमेल. ओके, इन द ग्रुप. ओके, यहाँ कोई फायदा नहीं, मुझे कुछ याद ही नहीं है. मुझे याद है nb.nic. सो मैं ग्रुप में कर दूंगा. ठीक है, सो आई विल राइट द ईमेल एड्रेस कंटेंट इन द ग्रुप. सही है? तो भाई सब्र करो, थोड़ी देर मेरे को भी खा पी लेने दो. ठीक है, आई डू. ओके, चलो, टेक केयर, बाय बाय. ओके. हाँ भाई, हाँ तो ठीक है, उसका ना जैसे अभी क्लास है वैसे लिंक देना. हाँ क्या क्या? हाँ वही 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 बिल्कुल वैसे है जैसे आज क्लास हुई है, लिंक दे देना. मैं लिंक पर लॉगिन कर लूँगा. ठीक है, ओबीएस की सेटिंग जो है वो ऑन करना मुझसे. ठीक है यार, मतलब यहाँ पे क्या दो अलग अलग टीम है हमारे पास, मतलब जो क्लास की टीम है और जो उसकी. फिर रूम पे करना है. ठीक है ठीक है, चलो ठीक है, तो दे देना मुझे रूम पे सेटिंग करना है. ठीक है, मुझे लिंक दे देना. ठीक है, ओके ठीक है. मुझे एसएमएस ही करना, व्हाट्सएप मत करना. ठीक है, मेल कर देना या व्हाट्सएप कर देना, और एसएमएस करना, व्हाट्सएप मत करना. पेमेंट हो जाएगा. हेलो, हाँ सर. हेलो, नहीं खत्म हो गई तो बंद करा नहीं रहा है, क्या हो? अच्छा अच्छा, मैं यहीं से बात करता हूँ, एक मिनट.